I appreciate the introduction, Bruce. I realize I'm not in Texas right now, and in Texas all meetings kind of start with either an invocation or a confession. So I'll say the invocation, go to the confession. My CD says I'm an internist, and that's true, but what I need to tell you all up front as part of disclosure is I originally trained in psychiatry. Okay, said it, I feel better. I actually even practiced psychiatry for a couple of years, and I don't know whether I got sick of it or got cured, but I switched over to internal medicine, and of course, much to my chagrin, I found I was practicing more psychiatry and internal medicine than I was in psychiatry. Well, now for the past 25 years, I've been in healthcare administration, and I swear I'm doing a hell of a lot more psychiatry than I ever did in clinical medicine. So I'm proud to be here, proud to talk to you all, and some very exciting things going on that I think is really kind of fun. And I'm one of those physicians that's real positive on the field, and I think we're going to do great. We have some changes to make. Many of them really are not pleasant, but as you're going to learn today, things like that. I put this slide up just to sort of depress myself, but here's where I've spoken in the last few years. It's been a real privilege to go all around the country, been in all 50 states, and two things I've learned is every medical system that we deal with is unique. Every medical group, every hospital, absolutely unique. All right, but then, once I'm there, once I get in a room like this, and the geography, I don't know where I am, or I don't know where I am anyway most of the time, we wind up talking the same issues, whether I'm in Portland, Oregon, or Portland, Maine. So I think a real key for you all is to how to better understand our health system, how to better make an impact, is this almost paradox, where every system you talk about is truly unique, but we're all dealing with essentially the same issues. And I think that's a powerful message for those of us that go around the country, or those of us that are dealing with this 20% of the GNP. This is a big deal. And when we talk about some of the things that we have to do, they're going to have major implications. Winston Churchill said it best years ago. He said, you can always count on the Americans to do the right thing after they've exhausted every other possibility. And you know, honestly, sometimes I think that's where we are right now. Well, a little pearl I learned in psychiatry. Here's a take-home for you. A little pearl that we learned first day in psychiatry. They said patients do not change until the pain of staying the same exceeds the pain of changing. All right, another way of putting it, you don't stop getting what you're getting until you stop doing what you're doing. That's 99% of psychiatry right there. You know it. That's it. That's what I learned. That's why I left. But when you look at healthcare across the United States, we're not feeling the pain. Last year was one of the most successful years ever for hospitals. Last year, 2015, physicians were compensated at a higher rate than we ever were before. Patients were seen. The system ain't broke. What I want to spend a minute on, and again, Mark touched on this, but the consequences of this price transparency. Because everybody loves transparency, good idea, and then I can say, wow, it's done just terrific things in quality and outcome. But let's talk price for a second. Several things we're seeing. The increasing costs going up faster than employers can afford it. What's it doing? They have to make up for that. They pass it on to the consumer in terms of either higher deductibles, co-pays, etc. When we look at the exchanges now, the 20 million people that he said are now being covered that weren't covered before, yay, good. Over 80% of them are signing up for high deductible plans. So all of a sudden, man, this price stuff matters. This makes a difference because the patient is paying more out of pocket. We're going to see a greater than ever demand. It's not a bad thing, but it's what we're seeing. Does it make a difference? The average premium, single premium deductible has gone up 400% in the last 3 years. It's not uncommon now for folks to have deductibles of $5,000, $10,000. And you know what? I'd like to see in your community, if you look at the studies, the average deductible is about $3,500 for a family. I'd like to see a simple study in my community, Austin, or your community. And that is, I'd like to see the average deductible for your community and the average amount that person has in a savings account or checking account. I'd like to see those things. I'm not quite sure they jive. Now, do they make a difference? I mean, myself, a year ago, and Nick, you know this, I was in my boat, taking battery out, and I cut open my index finger. Sliced it open, I could see the tendons, I checked it out, it was basically okay, but I knew I needed stitches. I also knew I was on staff at this hospital. I could make one call now. By the time I get there, I didn't have to worry about the ER. I'd go right on through. They'd get me a train. If not, I'd sew it myself. I wasn't worried about it. But I also knew from doing financial studies it was going to cost me about $1,700 out of pocket. $1,700. So I'm standing there on my boat with my dripping finger, and within arm's reach of me was a roll of duct tape. Well, guess what I did? I wasn't gonna pay that $1,700. Did this? So what we're seeing, the consumer is empowered more than ever before. I wrote an article last month. So nothing gets done. In fact, there was a recent study out of JAMA that showed one of the reasons we may be bending this cost curve is actually consumers aren't using stuff because of high deductibles. All right, so they don't know it. Then something happens which causes them to use that deductible. Here's the schizophrenia. Then it's quite the opposite. Hey, in the next 6 months, man, I got to get every surgery known to man. For me and my kids and everybody. So we're seeing this goofy behavior in me, in you, with these deductibles. But the bottom line, when I'm asked around the country, what do you think the biggest game changer in healthcare is for 2016? It ain't the ACOs, it ain't the ACAs, all that kind of stuff. It is very simply this high deductible and the effect that it is having on every one of us. So we need to manage that. We need to look at it. Yogi Berra, the late great Yogi Berra, said you should always go to other people's funerals, otherwise they won't come to yours. Wasn't he great? Wasn't he? Now, I don't remember him really, but my parents used to speak highly. No, I'm a wonderful guy. It occurred to me, I love his stuff. When you come to a fork in the road, take it. A nickel ain't worth a dime anymore. There's a whole bunch of them. Did you ever wonder whether he really said that stuff? So one day I Googled it, checked it out. He said, I never said most of the things I said. So we got that. Put that one to rest. So transparency. Now this whole changing thing of, I want it now. Consumerism. What the effect of texting. How it's changed what we look at stuff. I remember my college girlfriend used to write each other letters because we were in different cities. It would take like 3 days rather for the letter to get there. So I write a letter, 3 days later she'd get it, write me back the letter, so 6 days later. Then we got a little smart. Let's like write a letter in between the letters so we don't have to wait 6 days. You know, now it's all texting. Our kids don't wait 3 days for nothing. You text. In fact, even in relationships, I'm dumping you. Text. Done. Done. That's what we want to do. I want to talk for a second about this idea of practicing medicine on the smartphone. Because we can. These are the good old days. Remember this? Back, crank this phone again. I don't remember, but we have what we call party lines. Meaning, if I wanted to call someone, I might not be able to because someone else might be using it or more fun. Yeah. I don't need to make a call, but someone else is. Let's see what's going on. That's how it used to be until we got to now this 1960s, a private phone, man, your own phone. Well, let's go even faster. If you remember the day, April 3rd, 1973, Martin Cooper, the brick. Did any of you guys have a brick? Man, I got one. I thought it was so cool. I remember once driving in my car, calling somebody up with this humongous brick and saying, guess what? I'm in my car right now. Isn't this cool? It's changed. 2006, BlackBerry, which for those of you who had one also meant brick breaker. One of the most addictive games in the world. But now all of a sudden, all this stuff is now available. Our smartphone is not just a smartphone. It can do telephone, emails, internet, calendars, all the rest. How is this changing the future of practicing medicine? Anybody know what that is? Face it, when was the last time you put money in a payphone? I mean, I don't even know. I saw this in the Newark airport, but then I remembered I was in Newark. We now have billions of folks on smartphones, your apps, forecast to grow. Amazing what we now have. Future medicine, remember Star Trek? Did the doc have to know anything? No, the doc didn't have to know beans. All he did was take the scan and go, there's what you got. We're getting to that place. Look at all the stuff we could do, and I'd love to talk to you about hundreds of these. But in the interest of time, I just want to mention the one. You see the one that says ear exams there? All right, all you moms in the room, you young parents, etc. What happens at, say, 10 o'clock at night, your little kid's tugging at your ear, you know, darn well what they got, right? And now you go, all right, you going to the ER, am I going to the ER? Or I'm going to take off work tomorrow, what the heck are we going to do? And all the kid needs is a little bit of amoxicillin. Well, this app, which you can buy for about $50, put in a kid's ear, takes a picture of the tympanic membrane, shoots it through your phone over the ER, and now I'm the ER doc, and I'm seeing a picture of your tympanic membrane this big. And I appropriately diagnose in medical terms what's called amoxicillopenia. Meaning, now shoot the amoxicillin over the Walgreens down the road. How many of you as a parent would love to do that? right? Those are the things that are out there, and we can talk zillions of these, and they're growing like crazy. Monitoring. There's an app in many cities, including Austin, where you can just see what the wait times are for the ERs. So you're now at the baseball game, and your kid probably broke his arm, and you're going, oh no, this is going to suck. And I can look and see which hospital, how far away they are, and what their wait times are. Those are the things that we have. Telemedicine, and you're going to hear so much about this, and I just want to be brief on this. There are 4 issues that I like to talk about in telemedicine I think we need to consider. And as you hear the experts, folks in this room, they're going to be talking later, far more expert than myself on this topic. Think of 4 things we need to be able to do as consumers. Number 1, we need to ensure the quality of that provider. When you're looking at someone over Skype, I get it, I like it, this is great. How can you as a consumer be sure that that person knows what they're doing? Or is even in fact a physician? So that's an issue. Number 2, and this is a legislative deal, licensing. All right, telemedicine knows no state borders or country borders or anything. The way it presently stands, I have to have a license in every state that I practice. And by the way, maintaining a license is a pain in the butt. It costs about $1,000 per state per year, and then hours of stupid work you got to do to maintain these licenses. Most of us docs go, I want to have as few licenses as I can get away. Oh, by the way, if you put it on hold or something, in many states you have to reapply, so like you're afraid of dropping it, even though you're never going to be in Alabama again or whatever. It's a problem. We have to get the states to look at us. But you know what? That $1,000 for Texas, over 50,000 docs, do the math. There's a lot of money coming in there. But that needs to be solved. Third, and a couple of speakers have hinted on it, compensation. We need to figure out how to appropriately compensate. I'm not necessarily fee for service, but some kind of way of doing it. Because you know what? Who in this room does stuff that they're not compensated for any period of time? Right? Just simple.
The more clay we have,
And
easier
then
it is to
finally,
mold.
yeah, someone raise their hand. I want to hear this. Okay.
What time it takes to mold,
What
what
company
money
do you
it
work
takes to
for?
mold.
Because I want to hire you for the same
Right,
rate.
it'll keep it control your law. We'll be able to send out
Yeah.
something every 2 weeks.
And put it on your
Okay.
website, and
And then the
I'd
fourth
say getting
is some
that
degree of
why this
indemnification.
conference is
Meaning we
because,
know
all
that
the
seeing somebody on
individuals
TV,
unless they
even
talk
with
to
all
each
these
other.
devices, is not quite as good when I can look at the patient, touch the patient, palpate the patient, all this kind of stuff. Until we get to the point where they truly are equal, we need an ability to partially indemnify in those situations. And then finally, we're good. Finally, I think the biggest impact of telemedicine is not what people tend to talk about. When we think of telemedicine, classically, I go to Texas, and it's how do I get a specialist into West Texas? Or last week I was in Nebraska. How do you get a specialist into, rural Nebraska? Where I think it's going to be the most important is local. Simple example. You have a follow-up with your doc, and his office is 2 miles away. But you're in your office, and you're pretty darn busy. And for a 1 o'clock appointment, you gotta leave the office at 12, you have to go somewhere, park, sit in that stupid waiting room where you might catch God knows what, maybe the doctor's late, then you gotta drive back. A recent study showed that the average time that a patient takes going from office to come back, 3.5 hours. I don't know about you, but that's valuable time for me. If a doc says, hey, at 2 o'clock, I'm gonna Skype you, and then, by the way, maybe running a couple of minutes later, go, hey, that's fine, I'm at my office, I'm doing my stuff, and you just do it. Don't you want to do that as a consumer? And by the way, if I told you my routine office and recheck visit was $100, just to throw a number out to you, would you still pay $100 to do that same thing? Most of us go, hell yes. So I don't even have to be out of I can leave, stay in my office. What if you got kids? I don't need a babysitter, all this neat stuff. So as you hear from the experts on this, think of these 4 things. Ensuring the quality, the issue of licensing, developing a compensation mechanism, looking at some form of indemnification, and then realize a huge impact is going to be right here for your routine visit in a doctor's office is down the street. A study showed recently 30 to 40% of all ambulatory visits can be done through this medium. The average primary care doc is going to have to now retool. This is not a bad thing. But 30 to 40% of their potential time, their potential revenue is now going to be done this way. We need to retool. It's good, but it causes us to change. The natural history of technology. I'm going to get a little scientific here, then I'll drop it. But when you look at diseases, there's 2 things we look at epidemiologically: the incidence of the disease and the prevalence of the disease. Incidence fundamentally means how many new cases a year. And so that's how we can sort of look at this and conceptualize it. Some diseases have a high prevalence relative to incidence, meaning folks stay around for a while, like the chronic diseases, COPD, CHF, etc. Some diseases have a low prevalence relative to incidence. They like a pneumonia. I mean, you either get over it quickly or you die. Folks don't hang around with chronic pneumonias that long. Right? Appendicitis, a low prevalence to incidence because you got it. Something either happens and you're well or it doesn't. Now, why is this important? When we look at technology, a new technology, let's just say now for this graph, the red is our existing technology, then a new one comes out. If there's a disease with a low prevalence relative to incidence, meaning there are not a lot of cases out there, you're simply going to maybe just replace what's out there if you're lucky. And you won't replace everything, you'll replace a portion of it. Now contrast that, this is important, to a disease with a high prevalence pool. There's a bunch of folks with it out there, a bunch of folks who can benefit from this new technology, etc. What'll happen is a new product comes on the market, you have an opportunity to balloon your business to get all these folks in the prevalence pool that haven't already have a technology for them. So when I talk to a vendor about a potential new product, one of the first things I ask is what disease are you doing and relative to incidence and prevalence. This is my natural curve of a new technology. Meaning something starts, everybody loves it, everybody and their brother buys it, really cool, up, all of a sudden something happens. Poof, goes down, now nobody wants to use it. And then we all get smart, figure it out, and develop an equilibrium. When I look at like cardiac stents, man, when they first came out 15 years ago, what a cool thing. You can avoid surgery, you can keep a stent open theoretically forever, you can cure heart disease, all these neat things. So all of a sudden, everybody and their brother wanted a stent. Docs are putting these things in left and right. Till all of a sudden, something happened. They realized, oh my gosh, you can get stenosis, you can get clotting of these things, all kinds of stuff can happen. And everybody says, oh man, don't put stents in anybody anymore. So we went from doing one of these in our hospitals to, oh my God, don't put in stents. Until finally, we got an equilibrium. Realized, you know what? These stents do a good thing, but they also have some potential bad things, and here's the new equilibrium. And to sort of anticipate, as you put a new product on the market, that yeah, this might happen, especially if there's a high prevalence pool. Remember, those two go together. You have a real opportunity here to make a difference. So finally, how is the whole IT piece going to fit into this? And I love to ask non-IT people, anybody know what a zettabyte is? People in the room, you know what a zettabyte is? A 1 followed by 21 digits. All right, you know, iPhone 2025, that's the memory you're going to have on this thing. Right? I mean, when we keep doubling what we're doing. And in fact, the health community is so far behind, it's pathetic. I can take my credit card and go to Afghanistan and get cash. I can be in Austin, Texas, and the ambulance turns left instead of right. I wind up at my competitors, and they don't know jack about me. Right? Something's wrong with that. We should be able to fix that. We need you guys to help us. You know, and it's not just HIPAA. That's a bunch of junk. Because, yeah, I'm concerned about my privacy. But you know what? With my credit card, I'm also concerned about what's in my checking account and savings account. And maybe, just a little bit more concerned if someone found out I had tonsillectomy at age 5. Right? Now, that antibiotic shot I had in New Orleans 10 years ago, I don't want anybody to know about it. All right, it's not HIPAA. It's not HIPAA. I see tremendous potential of the electronic record and the ICD-10 methodology giving us a quantum leap. In fact, I believe that the EMR will ultimately do for healthcare what the assembly line did for manufacturing. You can completely revamp how this is done. It's going to change how we look at databases. Because in the past, all databases were descriptive. It told yesterday's weather. As we incorporate all these different systems in time, we're going to get to a point where we really have great data. And to me, it's really exciting as this moves ahead. And the connectivity is vital. Internet, big deal. You heard about this. If it's on the internet, it must be true. Where'd you hear that on the internet? We need to attack this issue. We need to deal with it. 61% of patients, if I refer you to a specialist, 61% of you are going to Google that guy first. Or girl. So I ask the docs, have you Googled yourself? Do you know what folks are saying about you? Because it's ultimately going to change our doctor-patient relationship. Are we going to go the way of the ATM? I don't think so. Because I'll tell you what, and those of us who've had a disease or whatever, That relationship is extremely important, but it will change. It will become from a model where the physician is in control to joint responsibility, face-to-face visits to remote access and information. So I reflected on these four with us. Transparency is the empower, the convenience, the natural history of the technology curve, and information tech. But it requires us to change. Like the Broadway musical, I love you, you're perfect, not change. Benjamin Franklin said years ago, when you're finished changing, you're finished. We are in the business of change. It means commitment. Here's a Texas slide. The goal is to have bacon and eggs for breakfast. The chicken is motivated, but that pig is committed. And then finally, this is my last slide. And I use this on all my talks because I remind healthcare people of this quote. It says, to the world you may be just one person, but to one person you may be the world. It's cool, isn't it? In healthcare, we're really blessed. We do incredible things. Our doctors, our nurses, our therapists do incredible stuff, right? And yet, sometimes things can get so crazy, the patient is lucky enough to get their meds that day, much less on time, and the nurse goes, why the heck didn't I stay and rock music? It's during those times. I want you to think about this, because I want to bet you when I talk to healthcare people, for every person that comes into your office or my office or your hospital, there is someone else in this world to whom that person means the world. And they're counting on you for their care. So thank you very much. Look forward to talking to you.